Yeah,
Yeah.
yeah, you're back.
Okay.
Oh, good.
Okay, thank you. Sorry.
Oh, never mind. No problem. So we are ready to start?
Yes, I am.
Okay. So first of all, let me introduce the webinar. First of all, it's a great pleasure for me to open the Pisa workshop of acute care surgery and trauma. The webinar formula, unfortunately, does not consent us to share our hands in presence, but on the other hand, it keeps us closer and allows a very impressive number of surgeons to participate. So thanks to everybody. The webinar is based on a series of debates concerning hot topics in the field of emergency surgery. And you will see a top-class faculty fighting in the arena for a pros and cons duel. The first duel will see Andrew Kirkpatrick from Calgary, Canada, and Maria Boermeester from Amsterdam, Netherlands, discussing about what to do after laparotomy for severe peritonitis. Before inviting Federico to introduce the speakers, I wish to thank so much all the participants of the webinar, all the faculty members, and most of all, Dario and Federico for the impressive efforts they made to organize the webinar. Thank you, everybody. Please, Federico, a brief introduction for Andrew and Maria to the audience.
This is easy because fortunately they have no need about introduction because they are the top expert regarding the issue. Andrew and Maria, they have been studying the several topics, but the open abdomen topic since almost 10, 20 years. I don't know the beginning, but they participated to most of the most important papers. Pro and cons, because we all know that Andrew is favoring even with his study, and Maria is not so favoring the open abdomen procedure. So we can see them fighting regarding a very debated topic. And I think we can go ahead without any introduction. Andrew is working in Canada, and he's the principal investigator of the COOL study, who is recruiting the patients with open abdomen after severe acute peritonitis. And Maria working in the Netherlands, and is even performing this technique, but with some concerns that are more than reasonable. So she's the real important woman who is trying to reduce the enthusiasm, sometimes the excessive enthusiasm in favor of the open abdomen. So we need her opinion regarding this topic. So I think that we can go with Andrew as first as in the program. But before starting the speech of Andrew, we would like to share a little votation in order to have the flesh of the opinion of the person who are listening to the speeches, in order to have even the confrontation at the end of the speech, in order to have to know if these webinars are useful or not. I will send this, so I think you are receiving, yes, the possibility to vote. You can vote on your screen, not the panelists, but the people from the audience. So I will ask you to vote in order to have an idea of which is the opinion. For the panelists that cannot see, the question is, would you consider the use of the open abdomen in patients with severe peritonitis associated with critical clinical conditions? Present, almost 100 people voted, and the 94% is in favor to the use of open abdomen. So a very hard duty for Maria in order to try.
It's impossible, impossible task. Okay, thanks, Andy.
I think so. You have good data, and you have. So I think people are almost done. So we have for the use in favor of the use, 94%, and against the use of open abdomen, 6%. So I think we can go ahead with the debate in order to try to modify the pooling. Okay, so please.
Okay, I'm going to share my screen now, if I may. Oh, sorry. It says the host, I think you need to enable me to share my screen.
You should try to use the link share screen, and then you select among the different windows that will open inside
It says host disabled. I think you need to allow me to share my screen.
Sorry.
Or I just need to debate harder with no slides.
You should be. Okay, sorry. Now you are enabled to share
Yes.
your screen.
Perfect.
Sorry.
Okay.
Good.
Well, if you can see my slides,
Yeah.
I want to thank you so much for this invitation from my good friend Federico for this opportunity. I was thinking more of a friendly discussion as opposed to a duel or a fight or a battle, but we'll see. But again, it's an absolute pleasure to debate one of the great leaders in surgical research and someone who I've considered a role model for surgical scientists all over the world, Dr. Boermeester. I actually feel proud as well and acknowledge the wisdom of the Pisa workshop team in selecting this topic for the inaugural debate, which confirms my opinion that this is the most important topic in acute care surgery today, and for one for which we all need answers. Sorry. Those are my disclosures. I'll admit I've consulted for Zoll, Innovative Trauma Care, Acelity, and SAM. Most relevant, as Federico mentioned, on the PI of the closed or open after laparotomy for source control after severe complicated intra-abdominal sepsis, or the COOL trial. And the final disclosure is that I'm a bit nervous debating such an esteemed colleague. Well, I could take the easy way out and just say that Federico already answered the question, 94%. That's a pretty good mark. I would have taken that in any course I took. Or I would just simply argue that we should leave the abdomen open because many smart colleagues around the world are reporting and recommending just this approach to try to do better with a group of patients that we often fail and have a high mortality. More and more, there are publications recommending use of the open abdomen for severe intra-abdominal sepsis because it may allow better drainage, it allows negative pressure peritoneal therapy, it mitigates intra-abdominal hypertension, and allows easier relaparotomy. But I suspect Dr. Boermeester will correctly point out that none of this has high-level evidence. So I could point out all the recent guidelines that have been produced by the Abdominal Compartment Society, the International Italian Consensus Conference, and even our own World Society of Emergency Surgery, who recommend the open abdomen with negative peritoneal pressure. But again, I suspect Dr. Boermeester herself will probably point out the weakness of these recommendations. And I'd agree, although still, these are what these organizations of smart people concluded. But as both yourselves and Dr. Boermeester will have higher standards, I think to answer the question as to why you should leave the abdomen open, I should reverse engineer the question to make it logical that there's only one answer. Thus, I'd like to briefly review the critical importance of complicated intra-abdominal sepsis, then review the pathobiology, review the evidence base of active negative pressure peritoneal therapy, and to review the suggestion that an open abdomen with negative pressure therapy might keep sepsis from becoming systemic. And finally, review why closing the abdomen too early will harm the patient. So leaving the abdomen open becomes the obvious as the only logical answer. So again, maybe this is irrelevant, but why is this topic so important? Well, I think we all know intra-abdominal sepsis remains a worldwide challenge with high mortality and ever-increasing incidence, being the second most common manifestation of sepsis. When the inflammatory process becomes systemic, mortality dramatically increases. Data from the Global WIS study, looking at over 4,500 patients in 132 centers, noted a 41% mortality rate with severe sepsis, although this term is now an oxymoron according to the new guidelines. And in the developing world, septic shock may have an 80% mortality. So although COVID is now ravaging our planet, sepsis has been doing the same since long before any of us were born. Globally, the World Health Organization reported that as of January 10th, when I made this slide, there were 1.9 million deaths from COVID, compared with 11 million sepsis-related deaths worldwide every year, year after year. So drilling down on those who die, most are from multiple organ failure. This reflects the sequelae of our local problem becoming systemic, with a dysregulated host response and progressive organ failure because of the elaboration and propagation of inflammatory biomediators. In addition to the biomediators we poorly understand, there's also the issue of the human microbiome, which we understand even less. We still have so much to learn, but humans are host to our gut microflora upon whom our health depends. There's 150-fold more bacterial genetic material than our own in the human microbiome. When subjected to stresses such as septic shock, the flora rapidly evolves into a pathologic dysbiome that potentiates the inflammatory cascade and contributes to multi-system organ failure. And further, all these catastrophic changes occur within the closed confines of the abdominal cavity, which is exquisitely susceptible to intra-abdominal hypertension. Such as our evolution has actually placed the microbiome time bomb within the pressure cooker of the abdominal cavity. Just taking a step back and looking at the basics of what it does, the open abdomen is a great way to remove peritoneal fluid, which might be critically important for critical illness. For the longest time, peritoneal fluid was assumed to be benign, but it's actually a sea of inflammatory mediators and may be a primary driving force for systemic sepsis. An ever-increasing amount of work suggests that intraperitoneal fluid after injury or illness contains this soup of mediators, propagates multi-system organ failure, and the behavior of this fluid discriminates between survivors or deaths. So now I'm going to try and make a case that as we know the abdominal cavity is not the biggest problem after severe intra-abdominal sepsis, we should look at ways of controlling the systemic propagation of inflammation that ultimately causes death by destroying the heart, lungs, endothelium, kidney, and central nervous system and whole body failure. So saving lives from intra-abdominal sepsis is not just about the abdomen itself. There are more important issues and more organs at stake once the cat is out of the bag. So if there's a way to keep the cat in the bag, we should think about it. In controlled animal studies, it appears that this is exactly what peritoneal negative pressure does, and the effects have been dramatic. Kubiak and colleagues randomized 12 pigs in a severe intra-abdominal sepsis model to 36 hours post-surgery therapy with either peritoneal suction drainage or a single passive dressing. With just a simple difference in peritoneal drainage, there were reductions in TNF alpha, IL-6, 10, and 12 in the peritoneal fluid, and more remarkably, reduced levels in the blood. Thus, presumably by better peritoneal drainage, these mediators never became systemic. There was actually also less organ failure. With improved PaO2 or FiO2 ratios, preserved urine output, and actually less histological damage to the lungs, kidneys, liver, and intestines. Emmer also applied advanced analyses using dynamic Bayesian networks to analyze the entire array of mediators. They concluded that inflammatory ascites was less contributory to the entire systemic inflammatory picture when the biometers were removed from the systemic circulation. There's also suggested evidence that improving peritoneal drainage after intra-abdominal sepsis is beneficial. Benchtop studies show that with improved temporary abdominal closure devices, the peritoneal cavity can be better drained mechanically. And further, Mike Cheatham compared the application of a less efficient but cheaper homemade negative pressure system, the Barker's Vac Pack, to a more efficient system, with the dramatic results that there was an association with significantly lower 30-day all-cause mortality. But the uncontrolled nature of the study requires caution. Nonetheless, in the conclusion, the authors suggested a potential mechanism for the seemingly profound benefits in suggesting that potentially the more efficient negative pressure may more efficiently remove the inflammatory cytokines that drive multisystem organ failure and death. We as well in Calgary conducted our own RCT comparing less and more efficient peritoneal drainage in the open abdomen, and noted an intention to treat 90-day mortality of 21% in the more efficient group versus 50% in the Vac Pack group. So to recap, why do I think you should leave the abdomen open after sepsis? Well, it will prevent intra-abdominal hypertension. It will allow for better clearance of inflammatory ascites, and it is a safe option. After I said that, I expect Dr. Boermeester to be sharpening her knives over the question of enterocutaneous fistula. And I agree, enterocutaneous fistula is a nuclear holocaust of the open abdomen and the source of so much grief. Thankfully, Dr. Coccolini's work with IROA has clarified that peritonitis, intestinal anastomosis, negative pressure, and oral enteral nutrition were not risk factors for enterocutaneous fistula, while the only true risk factors were the duration of the open abdomen and the nutritional status of the patient. So to come full circle, I should quickly review why closing the abdomen too early might actually hurt the patient. Simply, intra-abdominal hypertension equates to visceral ischemia. Further, there may be a failure to clear the inflammatory ascites, and intra-abdominal hypertension increases wound complications. So that closing an abdomen the first night too tightly that will eviscerate early or herniate later isn't helping. And I can imagine Dr. Boermeester will logically refer to her landmark work from the 2007, in which she conclusively proved to the world that a planned relaparotomy strategy had no benefits over a relaparotomy on demand approach. But I'll suggest this might be one of the world's misunderstood studies, with many otherwise brilliant colleagues assuming the relaparotomy on demand group had an open abdomen. But if I read the paper correctly, which I've done many times, this is not the case. The fascia of the relaparotomy group was actually closed, and thus this data, while valuable in our journey, represents a care paradigm from a previous generation, and not to be disrespectful, is not relevant to the modern discussion of the open abdomen managed with modern TAC devices. So I guess now I should wrap up. So to conclude, after severe peritonitis, you should leave the abdomen open when the case is severe, not just for every case, but with severe cases. So I will again defer to the recommendations of the World Society, who stated, the open abdomen is an option for emergency surgical patients with severe peritonitis and severe sepsis under the following circumstances: abbreviated laparotomy due to severe physiological derangement, such as you think they might arrest and you just want to get them to the ICU. The need for deferred intestinal anastomosis, the need for a planned look for intestinal ischemia, extensive visceral edema, where you're concerned they'll be too tight when you close, and again, for a persistent source of peritonitis, meaning a failure of source control. And to me, it's this last indication regarding source control that is obviously the most controversial, but power. But what source control are we actually talking about? Is it for the source of infection, the source of dysbiosis, the source of biomediated translocation? We don't actually know, but the evidence suggests that our very sickest patients should be left open initially after a laparotomy is required, and then closed as quickly as physiologically safe thereafter, unless you're participating in a randomized trial to really learn what to do. But I think that's a topic for our follow-up discussion. So again, thank you very, very much for the honor of being able to talk this morning or afternoon.
Thank you very much, Andrew, for this very interesting presentation. I would like to point out that regarding the indication in the guidelines, this indication, this statement regarding peritonitis was the result of a very long and fruitful discussion we had with Maria, because I don't know if you, Maria, remember regarding that statement. We discussed for almost 12 hours by email with the group in order to refine the indication. And this is the result of a lot of people, and especially Maria, she was right, who moderate because the statement was more tough and more strong regarding the necessity to use the open abdomen in more situations than the one listed. So she moderated, and she were absolutely right regarding that. So this is the result of the work of many people, and Maria as one of the main of the principal role in this statement. I think if Maria is okay, we can go ahead with her presentation.
Yeah, I'm okay.
And we leave the discussion to the end, and all the people who are listening, and they can even raise the hand, and they can intervene at the end with question, and by writing on the chat, and even by asking that question from because I can give them the possibility to speak. Okay.
Right. Good. Do you see my screen?
Yeah.
Okay. Good. Well, actually, I think what Andrew is saying about negative pressure and the benefits of negative pressure, I couldn't agree more, because I'm a very big fan of using negative pressure in the abdomen and on the abdomen. So that's not the disagreement. I think we mostly disagree on the application of the negative pressure, because I think that actually closing the abdomen is the cause of the lower mortality in both Aptera studies, and not so much the function of the, well, let's say sucking out the cytokines, because that didn't work in venous hemofiltration. That was the same concept, but then with an hemofiltration machine, that concept doesn't really work. But the fact that the Aptera closes the abdomen really quickly reduces mortality. Well, anyway, I will try to convince you of the fact that although there is always exceptions in severe peritonitis, but the general idea is to close the abdomen. I have to see if I can put this forward. Yes. First of all, to be completely open, my disclosures. Also, a consultant of, well, it's a facility in the US, but it's 3M KCI in Europe, but various other companies involved in open abdomens or repairing hernias after open abdomens. This is what we're talking about. These situations are horrendous. And this is something that we really, really don't want to. This is not modern day surgery anymore. But I would like to ask you a multiple choice question first. Which is the correct answer? And we'll switch to the ability to answer this multiple choice question in a minute. After an emergency laparotomy for severe non-trauma, to be explicit, intra-abdominal sepsis, you can choose one of 5 options. The abdomen is left open to prevent abdominal compartment syndrome even when fascial approximation is possible. The open abdomen is preferred without a temporary abdominal closure device, a TAC device. The abdomen is closed even under tension. The abdomen is closed whenever fascial closure is possible. If not, a TAC device is used. And the last one is open abdomen and a TAC device are necessary, and both components for abdominal sepsis treatment. And now, yes, we switch to the multiple choice. So if you pick your answer, preferably not your personal opinion, but so much as what do you think the evidence says?
People are voting now. So
yeah.
Just wait for.
Yeah, we wait a minute.
Yeah.
We've got, let me see, 178 people on board. So if they could rapidly think of the most appropriate answer for the majority of severe abdominal sepsis, not thinking about exceptions, but the majority. Can you show some answers already?
Yes, I show, yes. Stop voting, and then we can you see everybody, can everybody see the results?
Yeah.
Okay.
Well, it's good because I think we're getting there. We're getting there because my answer would be option D. The abdomen is closed whenever closure is possible. If not, a TAC device is used. So that's only 43%. So I only have to focus on the 57 others, percent others. And the second common answer is that it's the open abdomen is part of the sepsis treatment. Okay, so that's only 36% left. So we're from 94 to 36%. So getting there. Okay, I go on with my presentation now. Good. So the reasons to leave the abdomen open can be fascial dehiscence, necrotizing fasciitis, marked visceral edema, damage control surgery, abdominal compartment syndrome. Yeah, okay, when it is an abdominal compartment syndrome, I think we all agree. But for the rest of it, it is absolutely no reason to leave only the abdomen open, even not in an abdominal compartment syndrome. You don't leave the abdomen open, just open. If we at first can agree upon this, then I think if we have this 100%, I get less referrals to our intestinal failure unit. And another important thing is to realize is that if you have an open abdomen, the percentage of complications increases as the days to closure are progressing. And there is a kind of a sharp increase in percentage of complications at days 7 to 8. So after a week, you're really starting to get in trouble, but already at day 5, 6, the percentage of complications increase. And the factors that reduce the chance of closure is over-resuscitation, and that is really the biggest problem of abdominal compartment syndrome in the course of the disease of abdominal sepsis. We hardly ever see abdominal compartment syndrome. The only 2 exceptions of the last couple of years were patients with necrotizing pancreatitis that had a breakthrough from retroperitoneal to intra-abdominal. Colonostomy makes it harder to close, or any ostomy. Sepsis source not controlled, failure to use negative pressure therapy in the abdomen from the index laparotomy, and failure to use a dynamic traction element in the closure, so a progressive closure. Even in the WSES guidelines, which I was part of, luckily we had this statement in the end, debating it in Ireland, in Dublin. Temporary abdominal closure techniques without negative pressure wound therapy, which is MASH, bucket of bag, should not be applied for the purpose of temporary abdominal closure because of the low delayed fascial closure rate. So you end up with an open abdomen, like the picture I showed you in the beginning, and being accompanied by a significant intestinal fistula rate. If we have a patient with a septic abdomen, severe sepsis, I think, and I've practiced this now for a very long time, and we have not a very high mortality rate, is not a hit and run. It's not trauma surgery. You have to get source control, because that is the most important driving factor for the patient's recovery, or vice versa. If you don't have source control, that drives the mortality risk. Without a delay, you need a definitive solution for the intra-abdominal infection. And that also means no domestic cleaning, so not liters or buckets of saline into the abdomen. That only damages the peritoneal lining, which is a very important defense mechanism. And careful weighing the low risk versus low risk of your solution, surgical solution at the beginning versus the long-term outcome, and don't do an anastomosis in a hemodynamically unstable patient, because that will never heal, and a second hit will kill the patient. If you don't do this right and you use open abdomens left and right, you get this disastrous result. If you do too much relaparotomies, they end up in these type of patients that I get referred from all over the country. And believe me, this happens a lot. So first thing, we have to get out of the way, and he already guessed that relaparotomy is just for the surgeon's itchy fingers, and it's not beneficial for the patient. And I mean planned. If it's a directed relaparotomy, after a CT showing a problem, then of course you do a relaparotomy. This is the trial. It's already getting pretty old, but it still hasn't been any other randomized trials comparing on-demand and planned relaparotomy. And indeed, 90% of these patients had their abdomens closed because we close abdomens that can be closed. But what I particularly wanted to show you is that even in patients with diffuse and diffuse fecal contamination, the death rate is lower in the on-demand group. So planned relaparotomy increases mortality risk and morbidity risk in the combined endpoint on the right side here, in patients with diffuse fecal contamination. So even in that setting, you're not winning with opening the patient up without anything to do, but just if you don't have anything else to do, then just rinsing it. So the key points thus far are abandon planned relaparotomy and don't practice the principles of trauma surgery, because they don't apply for peritonitis abdomen. And damage control surgery is, to my opinion, something that you shouldn't practice in peritonitis. Now, the prevention of abdominal, enterocutaneous and intraatmospheric fistula is very important. And the most important reason to prevent that is a primary abdominal closure whenever that is possible. And this is a very interesting systematic review with the meta-analysis showing you all types of studies. They're in trauma, but a lot of them are in non-trauma. Most of them are in non-trauma. And they compare early closure of the abdomen versus delayed closure. Using a temporary abdominal closure device is delayed closure. And this is mortality rate. So you see the diamond here, and that is in favor of early closure. And the mortality rate is 12% for early closure and 25% for delayed closure. So it's reduced by half with a very significant p-value. And early closure is 2 to 14 days. And that's already getting to one of my first slides, that you have to close the abdomen within the week, maybe max within 10 days to reduce complications. And the delayed closure is what you get if you practice open abdomens. They close after months or months, and that's not even delayed closure, it's virtually no closure. So prevention is important, and no open abdomen is not an option. In this respect, leaving it open without doing anything, it is associated with significant complications, continuous contaminated large wound, fluid and protein loss, catabolic state, loss of abdominal wall domain, and development of intra-atmospheric fistula. So the role of an open abdomen in the management of severe secondary peritonitis is highly controversial. And the only reason, and I think it's relatively well written in the guideline I was part of, but the most important is if you abbreviate your intervention, it should only be in the exceptional case of hemodynamically very unstable patients, despite of high inotropics, or with progressive severe multi-organic failure while you're operating. And source control is number one. So if you deviate from that, you have to have a pretty good reason to do that. If you just open abdomens, leave them open left and right, you get these sort of complications, which is very laborious and very expensive. Those are patients that cost you tons of euros or whatever coin you have. And these are situations, yes, you saw in the systematic reviews, this is sort of late closure, but this actually is not late closure. It's a complete reconstruction. It doesn't have anything to do with delayed closure. It is a whole new ball game. It's reconstruction. So when primary fascial closure is not possible, that is a different situation. So if you can't close, or you close under tension, and that's something that you shouldn't do, then there are other options. And this is the second question to you as an audience. When closure of the abdomen after an emergency laparotomy for severe intra-abdominal sepsis is not possible, we have 5 options, which I lay for you. A bag closure is best. A vicryl mesh inlay is best. A dynamic tension suture device is best. A dynamic negative pressure therapy technique is best, or a mesh mediated negative pressure technique is best. Okay.
People are voting.
People, yeah, I think the people, the 184 that vote, I think they
Present, 70% voted. 72, 73.
Yeah, maybe just carry on if
75.
I may say so.
1 minute, and then we close the votation. So you have only 4 seconds to vote. 76% voted.
Yeah.
This is the results.
Yeah. Well, we're actually doing very well. Not good enough, since the correct answer is answer E. It's not in red, so it's not correct. The E is the correct answer to the evidence, and mesh-mediated negative pressure technique is best. But at least everyone is in favor of negative pressure technique. So very good, very good. We carry on, if I may. These techniques are absolutely no longer acceptable. Open abdomen and temporary abdominal closure is, if you can't close, I wouldn't deliberately leave an abdomen open, is an active progressive closure strategy. With Aptera, it is you cut away the excess drape, tear off the distal sponge, position them deep in the paracolic gutters, very deep to the back of the patient. Then you put on, so you have a foam under the spider underneath, and again foam on top under the fascia, and then one on the defect as sort of an inlay, and then you put on the negative pressure, you suck this down. But actually, this is a wrong application because there is absolutely no approximation. Another example is this: if you do it in a shark fin way, and you collapse with narrowing of the fascia. And it looks kind of ridiculous, but it's just an extreme example to show you that thereby you reduce the width of the defect. And that's what you should do. And actually you see here with the scan on the left side, before we did this was the pre-Aptera scan, was a defect of 14 centimeter width. And then with this device and shark fin, we're at 7. The same thing you can do with a mesh mediated traction. So it reduced the defect by half, and that's where the survival starts kicking in. So you can do this with, this is the octopus, the spider, then the mesh, and then the foam on top. And we usually also put some foam under the mesh, so you have double suction there. An example of a patient with necrotizing pancreatitis and abdominal compartment syndrome is usually the only compartment syndromes that we have. And stepwise, with changing the device every 2, max 3 days, we could progressively close at the 4th operation at day 10. Completely closed the fascia, took the mesh out at the last operation, and closed the fascia primary. Another interesting thing is to prove my conviction that it is actually the closure of the abdomen that makes the patient survive is the close-up trial we did. And the close-up trial compared Aptera or other ways of having a temporary open abdomen with a primary closure at the index laparotomy using a biomesh that put traction. So otherwise you couldn't have closed these abdomens because of the high tension on the midline, but by transferring the tension to a biomesh that was parachuted in, we could close the most extreme devices, the extreme abdomen's fascias at the index emergency laparotomy. But interesting is that you look at, we were able to close the abdomen in most of those patients, also on the long term, but the composite endpoint of major complications was really extremely lower in the biomass group, and that is due to the closure. The ICU days were extremely reduced from 10 days median in the open abdomen management group versus 1 day in the biomass group. The duration of mechanical ventilation was almost nil in the biomass group versus 4 days in the open abdomen management group. And that wasn't, and also less reoperations. The patient needing reoperations were only 25%, whereas in the comparison control group, 80%. So by closing the abdomen, you start curing the patient. What type of closure? Yeah, this is the question that I asked. Mesh, Bogota bag, zipper, negative pressure. The highest closure rate of the fascia you get with negative pressure with fascial traction. And also the lowest fistula rate. Why? Because the fistula rate depends primarily on the closure rate and time to closure. And when you close rapidly and you in abdomens that you can't close primarily, you have a low fistula rate, and that also helps very much in the recovery of the patient. That is also one of the statements of the WSES guideline, mesh-mediated traction with negative pressure wound therapy. And actually, these same studies, Chicken, for me, it is the proof that closure of the fascia goes hand in hand with lowering the mortality, and not so much the sucking out of the cytokines. again, and these very important randomized trial, higher closure rate here, primary fascial closure 71 versus 54% in the Barkovac, and hand in hand a lower mortality rate. And it's also cheaper to have the Apthera and the higher closure rate of the abdomen, because of, like we showed in the close-up trial with the biomesh, you have shorter ICU, so less complications, and it's a cheaper patient. So also in severe abdominal sepsis, close the abdomen whenever fascial closure is possible, no planned relapse, no open abdomen to prevent abdominal compartment syndrome when fascial closure is possible. The use of negative pressure with continuous mesh-mediated fascial traction is preferred. And if you have an open abdomen, if you can't close it, you use this temporary abdominal closure device as an active progressive closure strategy. And in case of using a TAC, close the fascia within 8 days to lower complication rate and lower mortality. Okay, thank you very much. I'm going to stop sharing my screen.
So thank you very much to Maria and to Andrew for very interesting and very tough presentations. I have two questions, and one question and one comment to Maria before opening the discussion and the possibility to have questions from the audience. You mentioned that the open abdomen in a peritonitis, if possible, should never be done, because it's something that is a really last possibility, and maybe you even suggest that the indication for open abdomen that they are usually used in trauma are not appropriate. This is right.
Yeah,
I understood well from your presentation, you are suggesting something like an ongoing resuscitation, even in peritonitis patient during the operative phase, in order to create the condition to close the abdomen, even in extremely sick patients. Did I understand well?
Yes, well, what I was trying to get rid of in the minds of surgeons listening is that just leaving an abdomen open without doing anything, so not putting in a temporary abdominal closure device, is certainly that I hope we can agree all 100% of surgeons across the world that that is not a good option. That is step one. Leaving it open without doing anything is not a good option. If you do your resuscitation correctly and don't overflood your patients, you also don't have to leave the abdomen open in fear of abdominal compartment syndrome, as we always close the abdomen and we don't see abdominal compartment syndromes, and we don't have a very high mortality rate. Actually, we have a very low mortality rate in our ICU.
We have two questions from the audience. Now I will activate the microphone of Francesco Forfori, Professor Forfori, who maybe can give his questions there directly.
Hello?
Oh.
Thank you. Thank you very much for the opportunity to speak to these very, very important speakers. I had two questions. I am an intensivist. My first question is there any score or any help to decide the severity of the peritonitis, and so as a consequence to help in deciding if the abdomen should be closed or not? Is the first question. And the second one is what is the role of enteral nutrition in the open abdomen patient? Should we start or not, or which advice could you provide to us? Thank you very much.
Andy, do you want to start?
Yeah, I am just on PubMed right now. In terms of the score, I know that Dr. Tolonen and Dr. Lepiniami's group in Helsinki looked at their intra-abdominal view and complicated intra-abdominal infections in the World Journal of Emergency Surgery in 2019. And they started to look at this question and they suggested a score, but it hasn't been validated. And so unless I'm missing something, my answer is people are looking at it, but I know of no validated evidence just looking to tell you whether you should close or not. And I believe it all is the physiology of the patient, although, and maybe I'm stealing the question a bit, though this whole question, when we went from 94%, I think, to 43%, I'd be happy if the answer was 50-50, because I honestly don't know myself. I'm biased that we have almost no real randomized data to answer this question. And we're giving you opinions based on our series, translation from lab work, and telling you what we think. And I do think we all hopefully can participate in the COOL trial on a global basis to answer this question. So that, and then enteral nutrition, I'm in favor of trickling into nutrition as early as possible for gut protection, and then just on a practical basis, seeing whether the patient is able to tolerate, and they'll often be intolerant, but I think trickle nutrition is better than nothing. And Dr. Boermeester?
Yes, well, a scoring system to decide whether to leave the abdomen open I think that would go directly against the point that I wanted to make, is that the only reason to leave the abdomen open if it's completely impossible to close it due to visceral edema. So I would always close the abdomen, and when I can't close it, I would use an Apthera or the competitor's negative pressure device, mesh-mediated fascial traction, sometimes shark fin. And giving the results of our close-up trial with biomesh, if I can just close the abdomen, I put in a biomesh to completely close it, because that is what lowers the mortality. So I wouldn't look for a score to determine whether I can close or not. I look at the patient and try to close it. And if I can't close it, I put a temporary abdominal closure device in. And nutrition, yes, enteral nutrition before parenteral nutrition. But as patients in the beginning of a severe abdominal sepsis usually don't tolerate enteral nutrition, you will always have them malnutritioned, undernutritioned. So we also start parenteral nutrition, as you want to have all the good things inside. Otherwise, patients don't have any building blocks to repair themselves.
We have one raised hands from Professor Cherugi, and if you go inside the question answers, we have 4 questions to be answered. So from the speaker, so you can read, or we can have even a direct conversation together with the answer.
Yeah.
So,
Yeah.
Professor Cherugi.
Yes, thank you. A very, very simple question for Maria. Will you change your mind at the second laparotomy? I mean, you take the patient again in the theater after having closed him the abdomen for a severe peritonitis, and you have a complication, and you decide to go back to the theater. You find again a severe peritonitis. Will you change your mind at this point?
That also depends on what is the cause of the severe peritonitis, and whether it's still able. There's still the possibility to close the abdomen. If the second operation, the relapse, is because of an anastomotic leak, then you have a whole different situation, because actually you have a second source of peritonitis, and those patients don't perform very well. So we disconnect the anastomosis, and put the enterostomy, both ends out as an enterostomy and as a mucus fistula. And usually at that point you can't close the abdomen anymore, and we put an Apthera in. But that is more due to the fact that there is a second source. There is there are not a lot of patients that we do a relab just for kind of a diffuse contamination fluids, because those patients we treat percutaneously. So if we just have fluids without a new source, we've had source control in the emergency laparotomy, then usually the second problem, which gives the patient another infectious boost, is just infected fluids. And we drain that percutaneously. We don't open them up, and they do pretty well because their abdomen is closed. So you actually contain it and drain it, and that works very well. But it starts with source control. That's why I'm so much against abbreviated laparotomies, because if you rush into it like you would do with the bleeding trauma patient, you have no source control, and you simply don't. You're not curing the patient. But it's just the concept is very important. The concept is source control. The concept is close the abdomen as soon as you can, or at the first operation if you can, and that translates into survival.
Sorry, Andrew.
I would just completely agree with Dr. Boermeester or Marja that it is all about source control, and leaving the operating room with a septic patient without source control would be like taking a trauma patient to the ICU that you haven't stopped the bleeding. That's the whole reason you were there. Right. I think the question is then, do you close or not close to provide negative pressure therapy that you really can't do with a closed abdomen? And I think that is the question that we need to study and have an answer, because a generation from now, if we don't actually study it, if we just have theories and opinions, our children will be having the same debate.
Now, I completely agree that in essence, if we all agree upon the fact that we don't leave abdomens open, but that we study the question whether a temporary abdominal closure device is a part of the sepsis treatment or not, which is exactly what the COOL trial is doing, but never leave it just open for the fun of it, and don't leave moderately ill patients open, then I think we've saved a lot of patients' lives, but also a lot of complications that need surgery afterwards. On the long term, I mean. So I think Andy and I kind of agree, maybe not on the mechanism of survival in these patients, but certainly on the most important question that lays before us.
Completely agree. Thank you.
I think that some of the questions raised from the audience, I don't know if Maria and Andrew can read the different questions.
Yeah.
From Japan, we have questions regarding which level of physiological derangement. So we did, and the COOL trial maybe will answer to this. There are questions regarding the position of biological prosthesis or synthetic or a dual mesh prosthesis, and regarding the drainage position inside the open abdomen. And we have rapid answers to these questions because we are moving to the end.
Yeah, which question? I can see a question, which mesh? Does any type of synthetic mesh, because you take the mesh out at the last step with mesh-mediated negative pressure. And don't leave the mesh in. That creates problems too. And because I can't read any other question.
Okay, I have in D and down, D and R. We have not. Can you see? Dr. Boermeester said that we should not use too much fluids to clean the peritoneum during laparotomy for abdominal sepsis.
Yeah. No domestic. Indeed, no domestic cleaning. You know, the lining of the abdominal cavity is a mesothelial layer, which is a monolayer, which we call the peritoneum, which has a very strong immunological properties to clean the abdomen. If you rinse and rinse and rinse, you damage that. And we in the relapse trial, we didn't allow any cleaning, just sucking out the contaminated fluids or whatever, sucking it out and leave it. And if you do in the trial, if the patient was randomized for a relapse, and we looked at those patients, 2 in 3, so every 2 of every 3 patients didn't have any contaminated fluid left because the body can take care of it itself.
Actually, Marcia, is that at the relaparotomy? At the initial laparotomy, I'm assuming we need to macroscopically clean the peritoneal cavity. I'm fascinated by, there's a Dr. Koobs here in Calgary studying the native peritoneal macrophage population, which I certainly never learned about in medical school. And he says just that irrigation may be removing these native macrophages that you absolutely need, but that's at relaparotomy, is it not the initial?
No, it's also initial. At the initial operation, you just only suck out whatever debris or contaminated fluids there is, or pus or whatever. You just clean it, you suck it out, and the small remnants, you just leave it to the body. And if you don't use all that rinsing and cleaning fluids, you have the body's own apparatus to take care of that. So that's exactly also at the first laparotomy.
I gotta admit, I have that challenge because I know that science, but it's still hard for me to leave like vegetables I can see.
Yeah,
so that's the hard.
But it may be, if we put it that way, is that maybe you need an Aptera to do the cleaning, while we just leave the body cleaning and don't damage the peritoneum. That is an interesting thought.
I don't know.
But
I think that
we also need the cool trial, I think. But I don't know, what does your protocol say? Is it allowed to clean at the first surgery then in the cool trial?
Yeah, absolutely. We did not dictate the amount of irrigation, and the cool trial mandates an Apthera for the open abdomen. The option of any mechanical traction is institution dependent. So if one institution wants to use the Apthera solely, if another institution uses mesh-mediated fascial traction, those will all be subgroup analyses. But absolutely, and as well, we really didn't talk about the direct peritoneal resuscitation protocol from Dr. Smith, I think, and is it St. Louis? But that's also permitted in the cool trial. And that's a very interesting topic too, that I think there's such quite good evidence from the single center that has not been replicated, but I always wonder if we should be adding that ourselves.
And by that you mean installation therapy?
Yes, of hyperosmolar dialysate.
Hyperosmolar, yeah. They also
there
have
is another question regarding exactly this topic, regarding the closure of the septic abdomen and the eventual role of the washing of so a sort of intermediate way between the open abdomen and the closed abdomen, with the washing throughout the drainages you put inside the abdomen to wash out the dirty. What is the opinion of the 2 experts?
Yeah, I wouldn't do the washout, as already stated, whether you call it rinsing or washout or whatever. Just leave the peritoneum and just only suck out the misery. But what you can do, and that is the thing that I would be for the future most interested in using, is not only using negative pressure, while you could have closed the abdomen, but using it because of the option of installation therapy. And I don't mean hyperosmolaric, but just a normal saline that drips in and sucks out, like a Veriflow system on an open wound, is installation therapy used in combination with Apthera. And that is very interesting.
Do you have, Andrew, do you have any opinion from the Professor Cavina question?
I may have missed the exact question, but I think we're talking about installation therapy. Um, the continuous lavage therapies of a previous generation for pancreatitis did not have any benefit.
No.
I do believe that the Smith work does involve hyperosmolar fluid, and part of the theoretical benefit is the hyperosmolarity in the papers I've read. And so I think, again, these are all potentially important techniques that need to be replicated and studied in randomized trials. And I think this whole area, we need more trials that can only be done on a collaborative global basis, because these patients aren't as common as we think. We remember them because they're so dramatic, but they're actually not as common as we think on a daily basis. So I won't give a final opinion, but we are very interested in the direct peritoneal resuscitation as an adjunct. I'm just trying not to make it change too many things at once at our institution, because then we're just taking away some of the power of cool. And we started with our protocol. I'm trying not to change it, but I see great merit in direct peritoneal resuscitation.
Right.
Last question from Professor Chiarugi, and then we have to move to the conclusion.
Sorry. I already did my question, so sorry.
I can see the question and answers now. I was looking in the chat, but now I now see that there is a different button where the questions are put in. Because there is one question from Beatrice Di Venere, who asks, not better a composite mesh or biologic? I think that is referring to the traction mesh, but if it's in combination with the Apthera and fascial traction, I would use just a very cheap synthetic mesh, because you take it out in the end. If you follow the close-up trial and you use a biologic mesh to put traction and try to close it primarily, but under tension, yes, but that's a different technique. So for mesh-mediated fascial traction and negative pressure, just a cheap mesh, and don't forget to take it out at the end. And it's always the problem that if you don't get closure in the end, which happens in about 1 in 4 patients, despite Apthera, you don't get closure, then you mustn't leave the synthetic mesh in, because that creates problems. That I usually, if I see that it doesn't work, I switch to white foam, low pressure, low negative pressure therapy.
Okay.
And any other questions? I can. There's a question about installation. I think we've answered that.
Yes, I think we answered to all the questions people did from the audience.
Okay.
So if no other question arise from the audience, I think we can thank you both very much for participating, and to Andrew for participating in early morning to our meeting. And I think
actually, can I just say that we would love to have anybody in the world that can get ethical approval to help us with the COOL study. It's been sort of tough competing with COVID, but we're really starting to roll now with, we're just opening Brazil and Turkey. We're pretty excited about that, but you know, we still have a long way to go. And if anybody can email me anytime, or just Google coolstudy.ca, I'd love to speak with anybody anywhere that's looking after these patients. So thank you for the opportunity.
Yeah.
Yeah, well, that's very important. I mean, even in my institution, I would love to take part of that. The only thing is that we usually get patients referred after the problem has already happened. So we don't get a lot of primary abdominal sepsis, since we're a tertiary center. But it's still, if you want to have 1 or 2 a year,
I will email you right after this, Marja.
Okay, great.
So in conclusion, I think that if I recall the invitation of Andrew to participate in COOL study, because it's very important effort, an international effort that Andrew is taking on, and maybe in the next year we will have some results. And this is very important because it will fix a very important point in the open abdomen use in septic patients. So please, if you can and if you want, contact Andrew Kirkpatrick to participate and go on the web to find out the COOL website. It's very easy and very direct. Thank you very much to everybody for participating, and to the people who had the patience to attend this meeting, and to the two speakers who give us a lot of important information and a really up-to-date point on this debated issue. Thank you very much to everybody.
And thank you for organizing, Federico.
Bye.
Ciao.
Everybody.
Bye.
Thank you.
Bye-bye.
Ciao a tutti.
Ciao a tutti.